You're welcome to this session. We are going to be looking at the obstetric procedures of coronavirus sampling, cordocentesis and amniocentesis, as well as tests of placental function. My name is Dr. Oboma Kaniyene. I'm a senior registrar in the Department of Obstetrics, Gynecology and Perinatology in the Obafemi Awolowo University Teaching Hospitals Complex, Ile-Ife, Osun State, Nigeria. We are going to be looking at this session using the following outline, and by the end of this session, you should be able to do an overview of prenatal diagnostic test, the applications and indications, contraindications, procedures and complications, as well as placental function test and the applications. Prenatal diagnostic tests are a collection of techniques used to obtain relevant clinical information about the biophysical or developmental status of a fetus before delivery. The most common of these tests is amniocentesis. Others include coronavirus sampling and cordocentesis. Tests of placental function are biochemical assays that predict placental function. These have, however, been replaced in modern obstetrics with alternatives like ultrasound scan, Doppler studies, and antepartum cardiotocograph. The most commonly performed prenatal diagnostic modality is amniocentesis, and the amniotic fluid contains amniocytes and fibroblasts shed from fetal membranes, skin, and the fetal genital tract. Amniocentesis therefore obtains a sample of amniotic fluid containing these cells for cytogenetic or biochemical analysis, and this is done transabdominally under ultrasound guidance. Typically, amniocentesis is done between 15 and 20 weeks of gestation. If performed before 15 weeks, it is described as early amniocentesis. And what are the indications for amniocentesis? Maternal age 35 years or above, because this age category have been found to be associated with a higher risk of chromosomal and congenital anomalies in the fetus as well as in the fetus. So it is indicated if the mother is 35 years or above. Also, history of a previous chromosomally abnormal child, 3 or more spontaneous abortions, that's recurrent miscarriage. If the patient or her husband has a chromosomal anomaly, and if there's a family history of chromosomal anomaly or maternal history of an X-linked disorder. Also, a previous child affected by a neural tube defect or a family history of neural tube defect is an indication for amniocentesis. Other indications include a previous child affected by metabolic disease or family history of metabolic disease, abnormal maternal serum screen, detection of sonographic abnormality associated with aneuploidy, such as diaphragmatic hernia, found to be associated more in fetuses with Down syndrome. Also, genetic amniocentesis is indicated for the diagnosis of sex-linked disorders, chromosomal anomalies, inborn errors of metabolism, and neural tube defects. Early amniocentesis, which is amniocentesis done before 15 weeks, usually between 11 and 14 weeks, is not done for genetic indications, as the cell culture failure rate is high. The cell yield at this gestational age is minimal, and so culture failure rate is high. Amniotic fluid may also be assayed biochemically for the presence of alpha-fetoprotein, acetylcholinesterase, bilirubin, lecithin, sphingomyelin, or phosphatidylcholine for neural tube defect assessment or fetal lung maturation. Spectrophotometric test for degree of fetal hemolysis in a resuscitated mother has been superseded by ultrasound imaging, though previously this was an indication for amniocentesis, but now medial cerebral artery Doppler has replaced that. Amniotic fluid may also be assayed for fetal viral infections such as cytomegalovirus, and then also provides a useful tool later in pregnancy at low risk for diagnosis of intra-amniotic inflammation and infection as a risk factor for preterm labor. Now, how is amniocentesis done? First of all, you should explain the procedure to the patient, and this applies to all procedures in obstetrics and gynecology, outlining benefits and possible risk, and then you should obtain a written consent from the patient for amniocentesis. An ultrasound scan should be done to visualize the contents of the uterus, particularly the lie and position of the fetus and placenta, umbilical cord insertion, and amniotic fluid volume. A suitable entry point on the maternal abdomen should be noted on ultrasound scan. The maternal bladder should be emptied. The mother should be positioned, clean and draped. And the proposed site of puncture is infiltrated with 2 ml of 1% lignocaine solution and using a 20 to 22 gauge needle. This is inserted transabdominally under continuous ultrasound guidance by the practitioner performing the amniocentesis. Continuous ultrasound visualization of the needle improves success of the procedure, limits fetal iatrogenic injury, avoids maternal bowel injury at needle insertion site, especially in those with a previous scar, and reduces blood staining of the amniotic fluid. Blood staining of amniotic fluid may affect assays for fetal lung maturity. So we don't want the amniotic fluid to be stained. The presence of blood in amniotic fluid may interfere with amniocyte culture also. Transplacental passage of the amniocentesis needle should be avoided unless that is the only safe access to obtain an adequate sample of amniotic fluid. In case of transplacental passage, placing the needle through the thinnest available part of the placenta is recommended. So if transplacental passage is completely unavoidable, you should look for the thinnest part of the placenta to pass the needle through. And then usually placenta cord insertion should be avoided. Tabo et al. Reported an increased rate of miscarriage following placental puncture. This is the more reason why transplacental puncture should be avoided. And then 15 to 20 ml of amniotic fluid should be aspirated. Now, this will explain why the procedure should not be done before 15 weeks. The reason is that at 10 weeks, amniotic fluid volume is only 30 ml. And so if you are obtaining 20 ml of that, that is tilting the fetus to oligohydramnios. At 20 weeks, it is 300 ml, 600 ml at 30 weeks, 1000 ml at 40 weeks, at 38 weeks, and then it reduces to 800 ml at 40 weeks and drops drastically to 350 ml at 42 weeks. For multiple dichorionic pregnancies, separate samples for each fetus should be taken, and indigo dye may be instilled to prevent aspiration of amniotic fluid from only one of the gestational sac. So you actually instill indigo carmine dye into one sac so that that will indicate that that is the amniotic fluid from that particular sac, and the one without the dye is the amniotic fluid from the other sac. A single or two separate puncture sites may be used. Either way, the miscarriage rate is higher than for singleton pregnancies. Fetal well-being should be confirmed at the end of the procedure, and then prophylactic anti-D immunoglobulin should be administered to rhesus D negative unsensitized women after the procedure. Amniocentesis is a potentially sensitizing event in rhesus D negative non-sensitized pregnant women, and the patient should be advised to report any uterine cramps, vaginal bleeding, or leakage of fluid following the procedure. Amniotic fluid sample may be sent for cell culture and full karyotyping or rapid karyotyping, or both. Cells are cultured until enough cells in mitosis are available for cytogenetic analysis, and this may take up to 2 to 3 weeks. So a full karyotype actually takes time. And then the advantage is that it examines all 23 pairs of chromosomes to exclude anomalies. On the other hand, rapid karyotyping allows examination of only selected chromosomes, usually 13, 18, and 21, as well as the sex chromosomes. The two common methods of rapid karyotyping include quantitative fluorescent polymerase chain reaction and the fluorescence in situ hybridization. Rapid karyotyping gives results in 24 to 48 hours as against 2 to 3 weeks for full karyotyping. The major disadvantage is, however, that other chromosomal abnormalities, aside those of the selected chromosomes, are not examined. If rapid karyotyping confirms aneuploidy, then full karyotyping should be done. In the case of Down syndrome, for example, this will help to determine if the aneuploidy is due to typical trisomy from non-disjunction or Robertsonian translocation involving chromosome 21 and other chromosomes like 13, 14, 15, or 22. Now, this is an example of an amniocentesis procedure. As you can see, that's the ultrasound monitor. The procedure should be done under continuous ultrasound guidance. Now this is using a 20 to 22 gauge needle. Now the needle is passed trans-abdominally through the amniotic sac, and then this is a sample of amniotic fluid obtained, usually 15 to 20 ml, and this is deposited in a test tube, which is then centrifuged so that the fetal cells are found below down here, and these are the cells that are cultured for DNA and chromosome analysis. Now, as you can see, this is the placenta here, and so the procedure avoids the placenta because, like we have said, transplacental passage is not recommended as it is associated with higher rates of miscarriage. So this diagram typically illustrates what an amniocentesis procedure looks like. Now, amniocentesis in maternal chronic viral infections. Now, what are the recommendations in mothers infected with HIV, hepatitis B, or hepatitis C virus? It is best to avoid invasive prenatal diagnosis in maternal viral infections like HIV, hepatitis B, or C viruses, except if absolutely indicated, in which case the patient would have been adequately counseled on the risk of fetal infection. Now we'll look at these infections one after the other. In HIV, the risk of vertical transmission is not increased when the maternal viral load is low or undetectable. Antiretroviral therapy should therefore be considered prior to prenatal invasive procedures in HIV-positive antiretroviral drug-naive women. And whenever possible, procedures should be delayed until treatment has optimized the maternal viral load. The placenta must be avoided at all costs in amniocentesis in HIV-positive women. The risk of vertical transmission of the virus is highest in the third trimester. Overall relative risk is 4. It has therefore been suggested that testing earlier in pregnancy is safer, provided the patient is on antiretroviral therapy and the maternal viral load is low or undetectable. In the case of hepatitis B virus infected women, the risk of vertical transmission is very low and also depends on maternal viral load. Women who are hepatitis B envelope antigen positive have a higher risk of vertical transmission, and amniocentesis should be avoided in them. As we know, hepatitis B envelope antigen positivity indicates active replication of the virus, and so the woman is highly infectious. Amniocentesis should be avoided in such women. For hepatitis C, data is limited, but there is currently no evidence that transmission is increased following amniocentesis. Now, what are the complications of amniocentesis? This may be maternal or fetal. Maternal complications include infection. Severe sepsis is seen in 1 in 1,000 procedures, and even maternal death has been reported following invasive prenatal procedures. There could be hemorrhage from transplacental passage of the needle or from uterine injury. There could also be transient vaginal spotting, amniotic fluid leakage in 1 to 2% of women. The fetal membranes could rupture pre-labor and with onset of preterm labor and delivery and prematurity. And then in rhesus D negative unsensitized women, they may actually be sensitized following the procedure. Fetal loss of between 0.5% to 1% was previously reported. However, more recently, it has been found that the fetal loss rate is as low as 0.11%. That's about a 10% reduction from the previously reported rate of 1%. And then there could be iatrogenic fetal trauma. Oligoabdinous from amniotic fluid leakage may result in fetal lung hypoplasia and talipes. Others include blood staining of amniotic fluid. This therefore indicates continuous ultrasound guidance, and this reduces the risk from 2.4% to 0.8%. Amniotic fluid cell culture failure is seen in 0.1% of samples, and this is increased in early amniocentesis. Now we go over to chorionic villus sampling. This is a technique used in the first trimester to obtain placenta tissue, that's chorionic villi, for cytogenetic testing. It is typically performed between 11 and 14 weeks. Now, I'm going to expatiate on this. Now, as we find out, 11 to 14 weeks is the same gestation where we do nuchal translucency for Down syndrome. And then it's also the same gestation where we also do ultrasound scan to determine chronicity in multiple pregnancy, as well as to date the pregnancy. So it means that at one scan at 11 to 14 weeks, we can actually do nuchal translucency for Down syndrome, determine chronicity in multiple pregnancy, and then do chorionic villus sampling. And then if early amniocentesis is indicated, it is this same gestational age. So that reduces the need for multiple ultrasound examinations in these women. It should, however, not be performed, that's CVS I mean, should not be performed before 10 weeks because of the risk of fetal limb reduction defect, whose risk and severity is highest when CVS is performed before 9 weeks. When performed after 10 weeks, the relative risk of limb reduction defect is 2.4 with an absolute risk of 0.07%. The excess risk is negligible after 11 weeks gestation. All of these goes to say that it is better to do CVS between 11 to 14 weeks and not earlier. Fetal loss rate. The advantage of CVS is that it is performed earlier in pregnancy, and thus the decision to terminate pregnancy can be made earlier. A drawback is the higher miscarriage rate compared to amniocentesis, and the miscarriage rate of 1 to 2% has been reported as against 0.5% to 1% for amniocentesis, and more recently 0.11% for amniocentesis. CVS can be performed transabdominally or transcervically under ultrasound guidance. The transabdominal route is the most common and preferred route because transcervical route is associated with a higher incidence of post-procedural bleeding and miscarriage. The transcervical route is indicated in cases where the transabdominal route is not visible or is associated with a significant risk of maternal internal organ damage. The transcervical route should be avoided in cases of cervical myoma, acutely ankulated uterus, uterine malformations, presence of infections such as genital herpes or cervicitis, or in the presence of vaginal bleeding. So if any of these exist, CVS should be done transabdominally and not transcervically. There is some evidence to support the use of small forceps as opposed to aspiration cannulae for transcervical CVS. The indications for CVS are similar to amniocentesis, but CVS is preferred for single gene abnormality. Also, unlike amniocentesis, CVS does not allow diagnosis of neural tube defect. So that is a drawback of CVS. So if you want to diagnose neural tube defect, amniocentesis is a preferred modality, as CVS does not diagnose neural tube defect. CVS also requires a higher level of skill than amniocentesis, and CVS samples also require meticulous treatment in the laboratory to isolate pure chorionic villi to avoid maternal contamination. Complications of CVS include procedure-related miscarriage, cleft lip and palate, digital amputation abnormalities, and oromandibular dysplasia, which is a combination of limb reduction, micronasia, or macroglossia. Now, this is a diagram showing CVS. This is a transcervical route. You can see the aspiration cannulae is inserted to obtain a sample of coronary villi from the placenta. This is the placenta. And then the same is done for transabdominal route. That's the placenta there, and that's the aspiration needle. And this is done under ultrasound guidance. That's the ultrasound probe there. Cytogenetic analysis of CVS sample. CVS samples, like amniocentesis sample, may be sent for cell culture, full karyotyping, or rapid karyotyping, or both. The tissue yield of CVS is more than that of amniocentesis. As we see in amniocentesis, cells are dissolved in amniotic fluid. But in the case of CVS, a pure sample of coronary villi is obtained. So it has many cells already in mitosis. And so tissue culture for 2 weeks becomes unnecessary. A culture karyotype is usually available in 1 to 2 weeks. For amniocentesis, as we saw, is 2 to 3 weeks because you need to culture the cell to obtain adequate cells in mitosis. In CVS, that is obviated as there are already enough cells in mitosis. Placental mosaicism may result in false positive results in 2 to 3% of cases. Mosaicism is detected in 1 to 2% of all CVS samples and at least 4.8% of term placentae. Mosaicism occurs as a result of either post-fertilization mitotic non-disjunction of a normal gestation, or in the case of trisomic gestation, due to meiotic error with trisomic rescue. Depending on the distribution of normal and abnormal cell populations, which is what mosaicism means, there is occurrence of normal and abnormal cell populations, the ultimate pregnancy may result in mosaicism confined to the placenta or through placenta mosaicism. Amniocentesis should therefore be done whenever mosaicism is detected on CVS to confirm the diagnosis. So if mosaicism is detected on CVS, it's an indication to do amniocentesis. So a CVS may actually indicate an amniocentesis for further evaluation. Cordocentesis, this is also called percutaneous umbilical cord sampling. This obtains fetal blood directly from the umbilical vein under ultrasound guidance in aseptic condition. The question that should come to a curious mind is, why umbilical vein? Why not umbilical artery? I will tell us why very soon. Now, a 22 gauge spinal needle inserted through the maternal abdomen and uterus under real-time ultrasound guidance using a curvilinear probe. The needle tip is progressed carefully and it punctures the umbilical vein approximately 1 to 2 centimeters from the placental insertion. The umbilical vein is preferred because the artery is prone to spasm. The artery is more muscular than the vein, so it is prone to spasm and associated with an increased risk of complications. On the other hand, the vein is larger in caliber, causes less hemorrhage and fetal bradycardia. So these reasons explain why the umbilical vein is used in cordocentesis and not the umbilical artery. Cordocentesis is done at 18 to 20 weeks, though after 20 weeks, the risk of complication is lower. Now, this gestational age is not arbitrary. Before the gestational age, it is difficult to actually assess the umbilical vein, but from 18 weeks, it is easy or easier to assess the umbilical vein. So that's the reason for this gestational age definition. And also, after 20 weeks, the risk of complication is also lower. Overall fetal loss rate is 1 to 2%, and this may be due to bleeding, cord hematoma formation, infection, fetal maternal hemorrhage, preterm premature rupture of membranes, and preterm labor. All the information as obtained in amniocentesis and CVS can also be obtained from cordocentesis. So we are not going to go over them again. However, the most common reason for performing cordocentesis is for suspected fetal anemia or thrombocytopenia with availability of immediate transfusion if confirmed. Now, this we will see is very useful in rhesus isoimmunization. So if you do a middle cerebral artery Doppler and it is confirmed that the fetus is at high risk of severe anemia, then the cordocentesis is done to determine the packed cell volume of the fetus, and then that will determine the need for transfusion. So other indications include hemoglobinopathies, fetal infections, fetal blood gas, and acid-base balance assessment. An important advantage of cordocentesis is that result of cell culture for karyotyping can be obtained in 24 to 48 hours. Very rapid. Now, this is an example of a cordocentesis procedure. Again, this is done under ultrasound guidance. All these procedures are done under ultrasound guidance to minimize the risk of complications. And there is the umbilical cord. We said that the vein is punctured 1 to 2 centimeters from insertion. This is insertion here, and this is where it is punctured. So 1 to 2 centimeters from the placental insertion. And then you obtain, this is a fetal blood sample, and then for culture or biochemical assay, as the case may be. Now we now go to test of placental function. The placenta is an endocrine organ capable of elaborating a wide variety of hormones from precursors derived from both the mother and the fetus. Placental function tests assess the levels of these hormones in order to predict placental function. And we shall look at some of these hormones. We start with estrogen and progesterone. The amount of these steroids in serum as well as in urine of a non-pregnant woman is so small that they are generally undetectable by most routine methods. In pregnancy, however, They are produced in the placenta in 15 to 1,000 fold, and they become easily detectable with increasing gestation. Among the estrogenic compounds, estriol, which is E3, concentration in the blood and urine, becomes more pronounced than that of either estrone or estradiol. And normally, the total estrogen concentration of 24-hour urine samples rather than blood is preferably analyzed at various gestational periods to measure the functioning capacity of the placenta. The falling levels of estrogen in urine of a pregnant woman complicated by diabetes, hypertension, and stroke, or toxemia, post-maturity, abruption placentae, stillbirth, and unexplained fetal demise have been reported. So in pregnancies complicated by these conditions, if you find falling levels of estrogen in the urine, most significantly estriol, then it may be a predictor of fetal demise. In the first trimester, progesterone levels are equal to or slightly higher than the levels found in the luteal phase of the normal menstrual cycle. Thereafter, a gradual increase in progesterone level occurs, which reaches a maximum of 8 to 20 milligram per 100 ml or deciliter of plasma at term. Urinary excretion of pregnadyol, which is a metabolite of progesterone, increases from about 5 milligram in 24 hours at 15 weeks, increases up to up to 7-fold to 35 milligram in 24 hours at term. A marked or progressive decrease in urinary pregnadyol is suggestive of or evidence of placental insufficiency. Low levels of pregnadyol has also been seen in threatened miscarriages, and we shall now look at human placental lactogen, which is a polypeptide hormone produced by the intact fetal placenta unit. It's also called human chorionic somatomamotropin, chorionic growth hormone, and purified placental protein. The level of serum human placental lactogen ranges from about 3 mg per ml at 24 weeks to 7 mg per ml at term, and much lower than normal amount of human placental lactogen has been reported in threatened miscarriage as well as intrauterine fetal death. Alkaline phosphatase, specifically the heat stable alkaline phosphatase, were produced in the liver, bone, and intestine, and also found in maternal serum during pregnancy. Rises persistently beginning at 32 weeks. Low enzyme activity is not influenced by maternal age, parity, sex of the fetus, or weight or that of the placenta. Elevated alkaline phosphatase levels in the later months of gestation is related to and possibly is a measure of the mobilization of calcium from maternal bone in order to provide material for skeletal calcification of the growing fetus. Oxytocinase. The production of oxytocinase appears to be a reflection of the functional capacity of the placenta. As we will see, before the onset of labor, the uterus is quiescent and resistant to oxytocin stimulation. And this is mediated also by the placental production of oxytocinase, which actually metabolizes oxytocin. The enzyme is clinically detectable by the 12th week of gestation and increases progressively until term. Greatly elevated levels has been reported in cases of prolonged pregnancy and in multiple births. Now, the reason for this is not far-fetched. Oxytocinase metabolizes oxytocin, and so if the levels are increased, then it may be a predictor of prolonged pregnancy, because that means increased duration of uterine quiescence and elongation of onset of labor. A lower level of this enzyme is indicated of placenta dysfunction, which is seen in missed miscarriage, impending labor, after intrauterine fetal death, certain cases of preeclampsia, eclampsia, and as well as post-maturity. Elevated levels of pregnancy-associated plasma protein and placental protein 5 may be associated with specific pregnancy complications such as preeclampsia and placenta abruptia. Placental function tests have been replaced in contemporary obstetrics by more modern methods like ultrasound scan for fetal biometrics and biophysical profile, Doppler ultrasound scan to assess blood flow in specific vessels, as well as antepartum CTG These have more significant advantages over placental function tests as they offer a more direct prediction of the risk of both fetal growth retardation as well as fetal distress. In conclusion, the obstetric procedures of amniocentesis, chorionic villus sampling, and cordocentesis are invasive prenatal diagnostic tests that assess fetal well-being and development prior to delivery, the most common of these being amniocentesis. Placental function tests are biochemical assays that predict placental function and integrity. These have, however, been largely replaced in modern obstetrics by ultrasound scan, Doppler interrogation, and antepartum CTG. These are my references. Thank you.